Yeah, that's come up.
Hi everyone. Welcome to DHP Equality, Diversity and Inclusion Task Force podcast. And today I'm with Sasha, Cain. My name's Kieran Baines. I'm on a few of the episodes. You might recognize me already if you've had a chance to listen to some of the other ones. And we're just going to introduce ourselves. So I'm going to introduce myself, and then I'm going to invite Sasha to introduce herself. And then we'll talk about our existing work together, how we know each other, and then go into the topics for conversation today, which is around practice and supervision and EDI. So first off, I just to introduce myself, I am a practitioner, health psychologist, and I work in clinical settings with underserved groups around managing long-term conditions. And I'm also the EDI co-lead, although I won't be specifically talking with that hat on today. So, and then over to you, Sasha, if you want to introduce yourself.
So I'm Sasha Cain. I'm a practitioner health psychologist for the last 24 years. I worked in the NHS for a number of years and became, I think, the first appointed NHS health psychology consultant in 2004. And then for the last 10 years, I've been working in independent practice. So I'm doing lots of different types of aspects of health psychology work, delivery, as well as training and supervision of health psychologists, which is the sort of just bringing it back to the topic of this discussion today. I've been supervising psychologists for about 20 odd years.
A good amount of time, I think. So one of the things that we wanted to kind of bring forward today for transparency is that we do have a supervisor-supervisee relationship. I am the supervisee, just in case anyone was in doubt. And we have also worked together on an article around addressing difference and discrimination in health psychology practice. So we'll be touching upon that in the course of the conversation. And thinking about practice, thinking about supervision. I think that's, and then where we would hope to go from here, I think, would be how we end things. So with just to kick us off, I guess then I'm just going to check in with you, Sasha, about the technical context for the article.
Yeah, I was thinking about it earlier actually, and I was remembering that when I started thinking about the article, what I was kind of pre-article, what I was doing was kind of being influenced and exposed by the culture that was going on around us at the time. And I was noticing that there was quite a lot of change in the amount of dialogue that there was about certain types of topics, such as who can use female changing rooms and toilets, and then also which we wrote about in our article, there were also a number of really kind of horrific racist incidents of people dying in the kind of semi-custody or in the public at the hands of the police. So this was the kind of context that I was kind of thinking about. What are we doing as health psychologists in the context of this sort of social change and events that were happening? And that kind of drove me to think, because obviously as a practitioner myself and also supervising other people, I was thinking, how should I be doing this myself? How should I be talking to other people? What are the guidelines? And that kind of then drove me to look at, well, what do the HCPC say? And I was quite kind of surprised in a way. I think they just changed their guidance and had added in some more things around our duties to kind of notice discrimination and to act when we notice discrimination. So again, I was thinking, okay, so what's the guidelines around that? What is it that we're supposed to be doing? A bit like you, Kieran, I've kind of worked a lot in services in London in particular, where there's very kind of diverse ethnic range, also, lots of different people attending services with different sexualities and backgrounds and disabilities, and so lots of kind of diversity there, and just thinking, you know, well, what's the guidelines, what are we supposed to be doing? And I suppose what I felt was that there wasn't that much there, and that started making me think, maybe I need to talk about this more with supervisees, and you know, start to open the subject. And I guess that's where you and I sort of connected on the topic, really, wasn't it?
Yeah, and I think I remember that conversation and thinking, you know, the HCPC would like us to talk, you know, raise issues where discrimination occurs. And I remember feeling quite frustrated, you know, about that, because, you know, that can put some of us in a more precarious position if we are raising those issues.
Yeah.
You know, not being seen as enough of a team player, being seen as difficult if we do raise these issues. And, you know, that can be a vulnerable place for anyone, but particularly if you happen to identify with, for example, visible, invisible difference, and you make that visible, then that can be, you know, an added layer of challenge. And I think I raised that with you and shared that frustration with you.
Yeah.
And that was what led me to be involved with the article, you know, when you kindly invited me to be part of it.
Yeah, and kind of thinking about ourselves as individuals was an important aspect of that. I found that really useful reflection. You know, I know from my own kind of experiences of, you know, being a woman in meetings, that, you know, of the kind of impact that, you know, that there can be if you're trying to raise subjects and you're the only woman in a meeting. And then there, of course, you know, we can intersectionally think about all sorts of other things that we present with as individuals, which can then make it difficult. And also reflecting on having worked for many years in the NHS, and, you know, most organisations, I'm just mentioning the NHS because that's an organisation I've worked with for a long time, but most organisations that work with the public in some way, there are inherent problems that prevent access of certain groups. So in a way, we've kind of lived with it for a long time. And then it's the challenges that we, you know, as psychologists, we're often advocates for the client anyway, aren't we? You know, let's say in multidisciplinary teams, for example. But again, then it's sort of putting the emphasis on us. Although, to be fair, it is an HCPC regulation across their registrants. So, you know, in effect, it's for all of those groups that are registered with the HCPC. But of course, for us, it's thinking particularly about how does that impact us as psychologists?
Yeah, absolutely. And there may be times when certain types of discrimination we may notice. Certain types of, you know, overt discrimination we might pick up on, you know, but whereas something that may be more covert or structural may be a thing that we may not pick up on, or may not feel equipped to pick up on, or may not feel very informed about. So, you know, in practice, what does it mean to address these things?
Yeah.
How do we, you know, what do we pick up on, and how do we go about doing it? So that's what felt a bit that it was like it was unclear, you know, from my perspective, and, you know, I think from yours as well.
Yeah, I think you're right as well, that what we tend to notice more is clients who access services and who are able to express to us the ways in which they feel discriminated against. But one of the big areas, which certainly I noticed when I was in the NHS, is who isn't coming to services. And, you know, that's a much bigger issue, isn't it? And it's much harder to hear from people when they're not necessarily present in the services, because the nature of, you know, the service delivery or the way the service is described feels excluding to them anyway. So they're not there to tell us why they're not there, if you know what I mean.
Yeah, absolutely. And, you know, on that theme, funny enough, I know that there's also not so much data that's collected, if you think about it. You know, I know that this is more of a mental health perspective, but, you know, certainly, you know, people, the global majority, you know, who would be racialized as Black or Asian would not be seen so much in primary psychological therapy services, you know, they'd be seen at secondary and tertiary care.
Yeah.
So, and that, you know, that does jump out to me, you know, for various reasons. And I look, you know, I've explored that with people that I supervised before, you know, using something like the social ecological model to think about what the barriers and enablers are. And, you know, well, knowing that is one thing, in all fairness, addressing it is also another aspect of it. So what does it mean to raise topics of discrimination, and you know, coming back to it, how do we do that? But also the other thing is, in the health psychology context, that, you know, in terms of data, we can only infer things. You know, for example, we know that, you know, that one of the longest standing issues in my field, I work with a lot of people with sickle cell disease who primarily are, you know, Black, Asian, and of Mediterranean origin. And, you know, for a long time, you know, the work that the funding for service inclusion, for access, and for research, you know, compared to people with similar, you know, proportions of, you know, say, for example, having cystic fibrosis, which mostly impacts white people of white European origin, the funding would be something like 7 times smaller. You know, so how do we even, you know, tackle discrimination when, you know, we may not see it unless we take a more proactive approach to thinking about whose needs are underserved.
Yeah, and breaking it down further from there, there are certain groups where there's more awareness of difference. Like, you know, you and I often talk about the fact that when we talk about difference as a society, often it ends up being about racial differences, and there's less discussion about other types of differences. And you see the same thing, you know, where there was the work that was done around deaths of women in childbirth from various different ethnic groups compared to white groups. So, you know, there's more in certain areas, and then if you kind of break that down into other areas of difference, there'd probably be a lot less data for us to draw upon.
Absolutely, especially where there's intersectionality involved.
Yeah.
You know, I know that, you know, there was a little bit of work around you know, respiratory illness. I think it was COPD actually amongst the LGBT plus adults in America, and finding that, you know, the people who are identified as sexual minorities were more likely to get COPD earlier. And then thinking about that, you know, what did that mean for COVID, you know, a couple of years ago?
Yeah.
So there are things, you know, but there's very little data on that, and there's, you know, probably in some ways quite obvious issues with collecting that kind of data when it's something that may not be so visible, and there may be more stigma. I think one of the actual things that I find surprising that we don't talk about more, given that we work with people with long-term conditions, is how much we don't talk about the stigma of having a long-term condition or disability. You know, how that can impact, you know, access to healthcare services, impact, you know, relationships with healthcare professionals and the system. And, you know, in terms of disclosure, all sorts of things, because perhaps it seems more ubiquitous and therefore maybe easier to overlook.
And also, I think from my experience of supervising lots of health psychologists, the type of work that we're doing with clients is often quite focused, and people are not always, psychologists are not always doing holistic work with the individual. So, you know, for example, one of my supervisees told me explicitly about a client with a long-term condition where the work that they were doing was around his experiences of racism and how they affected his ability to interact with health professionals that were helping him to manage his condition. In that circumstance, it became a kind of core aspect of the work that the health psychologist was doing with the client. But in the vast majority of cases, I think it wouldn't necessarily even come up in conversation, because there would be much more of a focus on sort of specific health psychology outcomes rather than looking at you know, for example, how the cultural management of their condition in, you know, within their culture might be different from another client that we might see. So I think there are ways in which we can work with clients where we look at that as being a kind of core part of what we do. But I think underpinning that is also, you know, we've talked a bit about the lack of kind of data to draw upon in terms of broader sort of health inequalities and outcomes and problems, but also it's within our own field in terms of what interventions we should be doing and what works for who, and what do the models tell us, and how do they integrate concepts of you know, difference and culture, disability, you know, the intersectional kind of groupings that our clients see themselves fitting within as being a sort of core part of the work that we do.
I do feel that sometimes what models that we look at are perhaps sometimes helpful in thinking about what we target, but not necessarily how, you know, those aspects, you know, of identity and experience can intersect with how we do things. Also wanted to name that we don't necessarily have the experience or tools to talk about how do we raise this, say for example, an assessment with clients, or but we do when we are, you know, witnessing you know, an incident with our colleagues within, say, our departments, you know, if we have you know, health psychologists working together, or with wider medical teams if we happen to work with them. You know, I appreciate that some psychologists may be, you know, more embedded in wider teams than others, but these are the kind of things that we don't really have a, you know, a blueprint to think about how we tackle those things.
And that's what I was looking for in the beginning, really, when I was doing my kind of initial searching. You know, what does the HCPC say? What does the BPS say? And actually, I mean, the HCPC have got a podcast that sort of talks about the standards, but they don't really address in their examples things that relate actually to discrimination. The examples that they then end up talking about is one, a very medical one, with a practitioner who doesn't wash their hands before they go and see a client. And of course, talking about discrimination is quite a different thing in terms of being quite kind of hot, maybe, topics. You know, depending on what the subject is, how it intersects with us as an individual, you know, how safe or vulnerable we feel to raise these subjects. And also, as I mentioned earlier, you know, there are a lot of systemic problems. So we're sort of almost part of the problem as well, aren't we? That we're, you know, we get used to working in these environments that are like this, and that can make us blind to it, but also, you know, make us feel a little bit hopeless about whether we can do anything about it.
Absolutely. I think there's a lot of that, or it might feel that, as you say, hopeless or overwhelming, you know, even to think about where do we start, where do we go from here, who might be, you know, prepared to do that with us, you know. Absolutely. And also, as you say, it's hot, but also the other thing is that where certain, you know, behaviors, if you like, might not be so perceived as personal. I think part of the other difficulty is that when we perhaps witness something where there's an incident or, you know, a lapse or an oversight, that people may take that as a personal attack, or, you know, think that, or say something like, you know, I'm not racist, or, you know, when actually what we need is to take a step back and kind of recognize that these are systems that we work in, and, you know, in some ways it'd be surprising if we didn't imbue some of the systemic issues that we see. So it was making me think actually about, in the article we talk also, because you were mentioning triggers there, you know, incidents that happen, and it was making me think about the part in the article where we were talking about that pattern that we have as a society, that something really terrible happens and then we all react to it and say, well, that can't be allowed to happen again. And then, you know, we find that as time goes by, we realize that nothing's actually changed again. So again, it's that kind of pattern where
we all rally round, but then there doesn't appear to be a kind of clear change. And I think it's the same in organisations, isn't it? Is that, you know, they'd be really helpful to have constructive policies on how to notice things, how to manage, you know, in a way, you know, it's managing risk. And, you know, in organisations, they kind of probably do that a bit better in a way of not blaming individuals, but trying to look at the system. Although, you know, I think there are still situations where people feel quite vulnerable if mistakes are made. So maybe it is part of a bigger picture of being able to make mistakes and how we handle them.
Yeah, and also, I mean, thinking about, you know, sometimes organisations will want to protect themselves. You know,
yeah, good point.
But I think that you know, before we think about how we navigate things in supervision, I did want to kind of say, and sometimes perhaps, you know, thinking about trigger points, you know, those trigger points that where things happen, they make certain aspects of our lives visible. And thinking about, you know, creating positive triggers, you know, there have been some of those things that perhaps we can take for granted otherwise. For example, Disability Awareness Day, Black History Month, LGBT plus History Month, those kind of celebratory events. How can we use that as an impetus, as well as the scary or upsetting incidents that might happen, you know, and that potentially is safer as well. So how can we highlight those things proactively? So there's something that comes to mind for me a lot.
Yeah, I think recognizing the things that go well is something that I try to do in supervision as well, you know, and not just focus on the problems. And I think it is important, if we keep these things as life subjects without moving on to what we hope for next, but more in terms of what I try to do in practice, is make it a topic that comes up regularly, because then I think it's more likely, or certainly I found that supervisees are more likely to raise issues because it's just a topic that we talk about a lot, you know, discrimination, or, you know, race or sexuality, or, you know, if those issues, if I'm asking about, oh, how did you think about, so for example, someone was telling me the other day about writing a talk that they were going to do a session on menopause, and I was talking about, oh, how are you making that inclusive for people who, you know, may be transgender? You know, what about people who are in same-sex relationships? So it's kind of just making that something that I try and proactively raise, because one of the things that, you, as you know, that I'm kind of balance along the way and talk about is, to what extent should I be responsive versus kind of proactive in supervision? So I guess that's the way I sort of try to be proactive about it. And also I try to raise it at the beginning of supervision when I first start working with somebody. And I have to say, there haven't been many occasions when I raise it as being a topic for discussion in supervision that it doesn't immediately trigger something from the supervisee around, you know, whether it's a personal experience or whether it's the client that comes to mind. So that I think that, you know, there are some ways in which when we are proactive, it actually can just be quite helpful. And that's kind of what I advocate with clients as well.
Yeah, absolutely. And I think, one of the things that I've done in supervision has been to add that as a topic for the supervision contract, you know, to make it clear that, you know, we can explore, I'd like for us to be able to explore how structural discrimination impacts the work that I'm doing in my practice. And, you know, so far so good. You know, that's been a positive addition to that, and made it you know, a permissible topic, you know, that we keep, you know, there in the conversation. I think also the other thing is that in some ways it's like, you know, as I know that I'm not alone in this, there's some research on this, for example, with LGBT plus people, that we look for, if you like, what would be termed green flags to be able to discuss these things. It gives us permission to be able to have those conversations about when things happen, or, you know, when we might be facing difficulties in our own practice. And that does you know, that makes a significant difference in terms of being able to discuss topics. And, you know, but that said, thinking about, you know, people who do experience marginalization as psychologists, you know, that having that stated in supervision and having it raised proactively in some ways isn't always enough. It feels a bit like, how do we make it safe? Because we are also human beings, and just because someone might have great intentions around making it a safe space to talk about discrimination, and especially where that might impact us, you know, our experience, doesn't mean that is always necessarily safe, because it can unintentionally come up in other ways, and then, you know, you can end up feeling reluctant to address it in case that actually it backfires, not because of intention, but because of action and perhaps what is unsaid or unsayable.
Yeah.
Wonder what your thoughts are about navigating.
Well, it's really challenging, isn't it? Because a part of me thinks it's a big risk for someone to take, isn't it? And I'm not sure what you do about that, because there's no way of controlling the outcome in a way, is there? Because we don't know what topic is going to come up, and we don't know what differences that might illuminate, or, you know, whether safety gets eroded. And I suppose my thoughts about that are around, similar to working with clients, is around good communication and kind of checking in. And I mean, and there can be some difficult moments, and, you know, there are conversations, without kind of getting into details, of conversations that you and I have had, where the next time we've spoken, I've said, do you know what, I reflected on what I said to you last time, and I was thinking maybe I wasn't being very helpful there. Maybe it would have been better to, you know, encourage you to take a different direction, or support you to be more active, or because there's always another way. And I suppose that's what I would say, is that possibly both parties in that situation need to be kind of active participants in it. And, you know, I do worry about saying and doing the wrong thing when it's about an issue which is not my personal experience, in the same way with a client, same but different, obviously, because different relationship. But, you know, it's about kind of having those explicit conversations about differences. And also the other thing for me as a supervisor and a practitioner is about trying to keep open to new information. So, you know, one of the things that I tuned into recently was the BPS HCPC webcast about supervision. And actually two of the kind of sections of speakers, I mentioned that because there were two together and then someone separately, so there were three speakers, were talking about things to do with kind of inclusive supervision, but also just recognizing that our models of practice are Western. So, you know, somebody came on and gave a definition of supervision, and then the person who came after said, but even that definition is a sort of Western definition, and if we were drawing upon African psychology, which is what the speaker was talking about, that we would maybe define it in a different way, or have core concepts of supervision that would be entirely different. So I suppose that's, you know, my kind of approach, is try to hear different perspectives and try to let it permeate down into what I do, and make me think differently about the way I talk to supervisees, or the way I may be open to different approaches.
Absolutely.
How does that sound?
Yeah, no, that sounds great. And I think it is something that, as a reflective practitioner, you know, also what I bring to that role as supervisee, you know, as some of it is just that willingness, I think, to work through some of these issues, because if you're able to do that, it can have a really powerful impact. And one thing I do like, funny enough, from the African psychology approach, is the idea of both and, you know, the idea of being able to draw from different approaches at different times flexibly. I think as practitioners, we're good at that. I can imagine that researchers say, no, we need to stick to a specific. That there are times when in practice it makes more sense to change tack and to try out something different or to blend things. And ultimately, one of the other things that I found useful has been I get supervision in my clinical context, as well as sometimes outside of that, having another perspective actually for me is helpful, and I feel very lucky to be able to do that. I appreciate that it's not always an option for everyone, but perhaps there are sometimes, instead of just, for some people it might be a group supervision setting, so they have some connections with other practitioners, maybe health psychologists, maybe other practitioner psychologists, but to have discussion with peers to reflect on these issues. There's more than one way to tackle that, and then think about how you might address issues. Ultimately, of course, sometimes if the relationship really isn't working, then of course you can move on and agree that perhaps it's not working. None of these things are set in stone, but it's
about a good fit as well, isn't it? Like it is when we work with our clients, it doesn't always fit. People are sometimes looking, they're two different approaches that can't come together.
Absolutely, and it's worth acknowledging that. But I suppose the next thing I was thinking about was how thinking about fit was thinking about how our social and historical context might impact what we feel safe and able to talk about. I wondered if you had any thoughts about that.
Did you have any examples?
So I suppose thinking about perhaps what we may have, what kind of discourses we may have grown up with, or what kind of issues we may be aware of. I certainly know that growing up with a lot of access to some of these these kind of issues, discussions around these issues with the internet has have allowed me to access information that that I really value, and has really shaped my practice over time, where it has pertained to some of the areas of difference that I've experienced, but also helping me to reflect on areas of privilege. And that's helped make it safer, but it also depends, as someone who tries to, to be supportive, for some the trans people that I happen to know. I am also very mindful and thoughtful about what I say and how much space I take up, and how I approach things, because of of my position, and to a certain extent allow myself to be guided by the people that I may be supportive of, and to try and make that proactively safe, to share their pronouns if they would like to, or not, but make it a safe environment for them to discuss if they feel that they want to. I wondered if there's anything for you that some areas feel safe or more familiar to talk about than others.
Yeah, and I suppose you and I have talked about our sort of experiences growing up, and I grew up in London in a very multicultural environment, but at the same time, I think as the years go by, I become more aware of what the limitations of that were, because when I grew up, I felt like it was a very kind of open and inclusive environment. But then I think, as you become older and you understand how people who have differences experience, what their life experiences are, you realize it's not about how you feel about it, it's what their experiences have been. So I felt like it was very inclusive, but I think there's that kind of sense, isn't there, in our society of I don't notice any difference. And I hear that as well in supervision when I speak to people and I raise the subject of differences. They say, well, I just treat all my clients the same. And in a way, I think that's part of the culture of a certain generation of upbringing in this country that felt like it was about not being racist, in this case thinking about race, but it could be expanded to other groups. But in actual fact, what it was almost trying to I don't know, was it assimilating, just sort of kind of imagining that everybody was the same as us? You know, for speaking as somebody who was born and brought up, and my parents were born and brought up in this country, that kind of sense. And then, you know, definitely at the time I felt like things were very inclusive, but I was thinking about this earlier today, that certainly I've become aware as I, you know, as I've grown up and connected, as you talk about the internet and the effect that that has, connecting with people that I went to school with, and finding that they've sort of come out, they've got, you know, they're gay, they're, you know, there whole things about them as human beings that were not evident in the school environment, even though I would have said at the time that there was no, there was nothing inherently there that stopped people doing that at the time, but there obviously was. And that's what I think
the one thing that comes to mind that I grew up with as well was Section 28 legislation as well. You know, that was only repealed in 2003.
Yeah.
You know, and that having a potential impact as in terms of the context.
And maybe not even entering the awareness, you know, it wouldn't even be on the agenda if it wasn't relevant to you, but it would be very relevant to you otherwise, and it would make you think, well, maybe I shouldn't say anything to anybody, or, you know. So I think that's the really, you know, a really important thing, is that there's a lot of stuff that's hidden to people when it's not within their kind of lifestyle or realm of experience. And as you say, there's so much that we just learn from other people that we have in our lives as well, isn't there, that we can get expertise from other people around us. And I know you and I have talked before about the division membership, and, you know, being inclusive and learning more about our members, because, you know, one of the things I talk about in I kind of mentioned in the article was the statistics about what we know about psychologists, and there, you know, there's a lot of information missing, but, you know, there wasn't really an awful lot about our division. So I think that's something definitely, you know, there's a lot of strength, I think, in our division to kind of lead the way and learn more about this, if, you know, we're able to be inclusive.
Yeah, absolutely. And, you know, certainly there's areas where you know, I think we can both relate to not being experts around, you know, what areas of difference and discrimination people might experience, but where we can, you know, as ongoing, you know, part of my ongoing CPD, if you like, to be able to learn about those areas. And yeah, I'd like one thing, you know, I'm just thinking about the next thing, we're thinking about what we hope for the future. You know, to then wrap up with, one of the things that I you know, think I really appreciate, for example, is having guidelines for psychologists around working with the relationship, sexuality, and the gender diversity. They're quite comprehensive, but I'd like more around that with other aspects of difference, you know, something. And I do feel that that's something that we miss, and perhaps something that, you know, we could do more, like we'd like, you know, for large institutions such as the BPS, it would be helpful to have those kind of those guidelines.
I agree, and also an approach, because you know, tackling discrimination when you see it is one approach, but another approach is to be proactive, and, you know, where do we stand as psychologists in this kind of discussion? You know, do we want to be, you know, actively positive, you know, anti-discrimination, or are we just noticing it when it happens and trying to do something about it? So I think that would be a really good thing to kind of come to some sort of agreement on as a profession. I mean, as psychologists, but also as health psychologists.
Absolutely. And thinking about how it can show up, you know, how it can manifest, how can we support each other to see it?
But also, and that goes back to training as well, doesn't it? Because, you know, one of the things that I have been looking at is, well, how are we helping our psychologists then? If this is what we're supposed to be doing, where does it fit within our training? And there isn't very much across the psychologies, apart from more general things about equality and diversity. And also in terms of self-reflection, particularly as a practitioner division. You know, I think it is really important that we do some work personally around what our own kind of needs and issues, and, you know, the things that could be barriers for us in our practice, and becoming more self-aware of, you know, the kind of the way we've been brought up, our own intersectionality, how that might impact, and also, we've been talking about it from a certain perspective, but of course, there's also things we receive from our clients. So what if our client is discriminating towards us? So there's different perspectives that we need to think about. It'd be really helpful, I think, to have some guidelines around that.
Yeah, and absolutely, and some like sharing opportunities to share practice as well would be really helpful. I think one of the things that I don't want to belabor it too long because it's a whole other topic, but thinking also about the health psychology models. Sometimes how do we consider that when we're using models? And I do wonder if one of the things that would be helpful is something like sometimes a more process-oriented approach rather than specific types of constructs that we target, such as self-efficacy or changing attitudes. What is the process of recognizing these issues and talking to our clients about it, talking to healthcare professionals about it, recognizing cues, thinking about the kind of outcomes that we want, I do feel that there's potentially a lot more room for that. And I think there are some other disciplines in psychology that they tend to do that a little bit better than perhaps we do. And is it a case of learning from that, so that we don't reinvent the wheel? Is there something that we can do to build upon it?
Yeah. And I'll just extend that also to add in that, it's really important that we understand what interventions are best for subgroups. And, a lot of our research tends to be dominated by, white British participants, which doesn't really give us an awful lot in terms of, well, what are the differences? And actually, from a kind of positive perspective, where different cultures might actually have helpful approaches that we can actually integrate, but also not having culture and individual differences sort of over there on the side, because actually it's a kind of fundamental thing to the way, I think the difference for a practitioner is when you've got a client in front of you, you need to figure out how you're going to work with them. We're not saying to them, I'm sorry, you don't meet the criteria for who gets the best results from this intervention. I'm not going to see you. We're trying to figure out, okay, how do I work with this person and how might I need to do it differently? Because the research was largely done with a different population group. And I know that's a big challenge, but I think, and it's easier with certain groups like potentially sickle cell, where you've got a large sort of a more sort of a larger homogenous group that you can work with there, that is a kind of non-white potentially group. In other areas, I think that it's not something that we really focus on, and I think that would be really helpful. And certainly when I do literature searches to say, what about this group with this condition, there's usually very little there that I can draw upon. That's probably a bigger goal.
I think the where it's easy in sickle cell is because like the racism is kind of the experiences of racism are visible. That the kind of stuff makes it a little bit easier. Where it's more difficult is that there's hardly any research, if at all, around psychological intervention. So you're kind of, if you like, winging it a little bit more. But there's certainly things that I've learned from practice around, okay, so if a client is ready, for example, talking about their experiences of racism and discrimination, sometimes that opens up avenues to think about, and how can we draw upon that to help you to navigate the here and now, to navigate the issues that you've experienced, this kind of thinking about the strengths that they've developed over time because they've had to, and how do we bring that to bear, and that might be sometimes with people with long-term conditions, who may have acquired that a bit later on, say, these are the areas, talk about stigma and self-disclosure and, dealing with microaggressions, what's helped you, to be able to deal with that. So, and, people are, genuinely incredible with what they do. And if they haven't had that, then, it's also an opportunity to acknowledge that some of those things are really difficult and to be present with. So either way, you're learning something and you're helping them in some way, in my experience. So
yeah, I mean, I think it can make your work more authentic, can't it? If that's a part of the conversation that you have, you know, whatever the difference is between you and your client, if you're able to talk about some of the things that might get in the way of you being able to manage your condition, or, you know, whatever it might be that they've come to you with an issue around, I think it just opens up a whole new area of work that you can be doing with them, and in turn in supervision. Because obviously, if it's something that you're discussing with your client, then it's something that you discuss more in supervision. But you know, it is figuring out, how do I raise that subject? So how do I bring that up with the client? And it doesn't have to be about racism, or, you know, it can be about differences. You know, there'll be different, because we know as a therapist that we're going to be different to our client, and that's part of what we talk to them about, isn't it? The fact that they're an expert in them, so they're, you know, it's a partnership. But I think, you know, learning how to raise that, or being confident to raise that as part of the subject, you know, whether you phrase it in terms of your culture, or the things that make you you, or the things that are really important about you that I need to know about, or, you know, finding phrases that can elicit some of that information. I think it can kind of help you to work on a different level with the client.
Absolutely. And just kind of, you know, thinking about that, you know, a bit like what you were saying with supervision, giving people permission to raise those topics with us. I think it's about giving people permission. And of course, sometimes it might be a bit easier. I know that sometimes I find it a bit easier to talk about racism than perhaps some of my colleagues, and it takes time. But, you know, but we have things that we do to certainly in my department, you know, to be able to help people feel a bit more able to talk to her. And even if it's not in that moment, you know, then a bit later. And I guess, you know, coming back to supervision, is there anything else that you'd like to see changing in supervisory relationships that we haven't covered already?
Well, I mean, I guess it's kind of integrating this into the model. And definitely that felt like that was coming across in the BPS HCPC podcast, that it should be something that could, you know, that is integrated into the work that we do and the things that we discuss with our supervisees. So I guess it's a call out to people who are supervising others to, you know, maybe kind of think a bit about, how much do I have these conversations, and is it something that I could be proactively raising? It's just reminded me as well that I think we've probably put a few references with this, won't we? So I can put the link for the podcast as well, so that people can take a look if they weren't there, and, you know, a few other papers and things if people are interested too.
And yeah, I think that'd be really helpful, because, you know, sometimes it's about navigating that, and, you know, and also thinking about, you know, as human beings, you know, I know that I'm certainly learning on an ongoing basis. You know, sure, we both are, you know, and nobody expects us to be perfect as supervisors or supervisees. We can only just try and help each other find the way. And, you know, as you say, use those other resources that are available to us.
Yeah, and I think it impacts our life as well. You know, it's not just about the work, it's about, you know, us as human beings, whether it's about the experiences that we have, or also just thinking about life, you know, because I talk about it constantly in my own situation as well, because it's just, you know, we're interested, I think, psychologists, in what makes people tick. And I think this just gives us more information about that, which is really kind of stimulating.
Definitely. Well, thanks very much for that. It was a really good conversation. We'll be releasing these episodes soon. Well, you'll know, because you'll be listening to it. And that's us over and out.
And thank you for asking me to do this as well before we finish. Thank you.
It's my pleasure. It's been really great to have you on. And